Hi everybody, I'm Dr. Laura Aaron and I'm going to be talking to you today about radiography. We're going to be looking at how images are created and how to determine whether an image is of sufficient quality to use for diagnosis. I'm a professor in the School of Allied Health and have been teaching radiography courses for over 20 years, and hopefully I can give you guys some ideas about how to look at an image a little bit differently. Technologists, which I am, a radiologic technologist, do not interpret images, but we do determine whether or not they are appropriate for diagnosis and whether they are sufficient for you to make the diagnosis from. So that's what we're going to be talking about today as we go through this. Before we start talking about images, let's talk a little bit about some other issues related to radiology that are important. First, let's talk about radiation protection. There are three cardinal principles of radiation protection. We all want to make sure that we protect ourselves when we're around X-ray. So first is time. Time, you want to spend the least amount possible around the X-ray beam. Distance, you want to get as far as you can from the direct beam. So if you're in a procedure where there's being X-ray use, step away from the equipment. When they're doing a fluoroscopy procedure, take one big step back. That one big step, when they have the beam on, can actually help decrease your dose pretty significantly. That's only when that's possible. When it's not possible to move and you need to stay close to the patient during the procedure, then you want to make sure that you're shielded and you want to make sure that you're wearing a lead apron at all times. Since you're ordering procedures for patients, you need to think about the amount of dose that they have. Sometimes their patients have a concern about the amount of radiation that they're receiving. So this is just something to kind of help you understand that a little bit differently. So for example, for a chest x-ray, that's 0.1 millisieverts typically for a chest x-ray exam. What does that mean? What's a millisievert? Well, you probably don't know, nor does the patient. The patient certainly isn't going to understand it. So what's important to know is to kind of be able to compare it to something else that we know. All of us living on this planet are receiving radiation every single day. And so a chest x-ray is equivalent to about 10 days living on this planet, whereas a T-spine is a 1.5 millisieverts, or equivalent to 6 months on the planet. A lumbar spine, 3 millisieverts, about a year. Upper GI, 6 millisieverts, about 2 years. And a lower GI, 8 millisieverts, about 3 years. So you can see that the more complex procedures are giving the patients more patient dose. Why does all of this matter? Well, the ionizing radiation exposure of the population of the U.S. has been changing over time. So back in the 1980s, if you look at the chart on the left, you'll see that background radiation was responsible for 83% on average of somebody's overall radiation dose, and that medical imaging was only 15%. And then there were some other things that were lesser percentages. But over time, as medical imaging has become more and more popular and more used, those numbers have changed dramatically. And you can see that in 2006, this had to be revised. Background radiation is now responsible for 50% of average dose, and medical imaging is responsible for 48%. So it's important that every time that you decide to order an exam that you consider whether this is the best option. So why has the dose increased? Well, there's a lot of different reasons. One is ordering exams. So there are more procedures ordered now than there were in the past. Another big reason is the use of CT and nuclear medicine. Those areas have caused a dramatic increase in the amount of dose that people receive as well. And additionally, there's something else with digital imaging called dose creep. In the past, images were created and they were on film. Now they're digital. Those images can be manipulated and changed, and a lot of them are causing more dose for the patient because the best images usually come from overexposing the patient. So it's technologists can actually accidentally give a patient more dose than they would have with a film screen image. So it's important to be careful whenever we're making these considerations about whether or not to order an imaging exam. This is another graph that breaks down the dose, the average dose to the population into more categories. So now it's broken the medical imaging into different areas. So you can see that computed tomography accounts for 24% of the average dose, nuclear medicine 12%, interventional fluoroscopy 7%, conventional imaging like your regular chest x-rays only 5%. So you can see that the biggest areas are again from CT and nuclear medicine where the patient dose is increasing. So what can you do? Well, there's a lot of things that you can do. You're going to be responsible for ordering exams on your patients. There's a lot of ways that you can go about trying to determine what is the right decision to make. So these are some resources that I thought I would share with you that you could take a look at another time to see what evidence there is. So first, there are the American College of Radiology appropriateness criteria. This is evidence-based guidelines to help you with ordering exams. Next is the Image Gently campaign. This is a campaign that's been sponsored by numerous healthcare organizations that looks at decreasing patient dose to pediatric patients. Our pediatric patients, it's very important to keep their dose low because they're actually going to live long enough for some of these cancers and things that could develop from these exams. So we want to make sure that we're making all the best choices with our pediatric patients. In conjunction with that, there is another campaign called the Image Wisely campaign, and this is dosed to other patients that are not pediatric patients. So this again gives you some good evidence-based guidelines and some good information. It also has information that you can share with your patients that's written on a level that is easier for them to understand. And finally, this is another great source that a student shared with me that gives some information on exams, exposure, and alternatives to exams so that you can think through some different options that are not using ionizing radiation. For example, MRI and ultrasound do not use ionizing radiation, and so can help keep patient dose low when that is a concern. Now let's get ready to start looking at some images. When we look at an image, there's several things that we're going to want to look at. First, we want to look at the positioning and the projections. So when we talk about the positioning, is the patient in the correct position for the examination? Are they appropriately positioned? Are there any kind of things that we could have done to improve the positioning? The projection refers to where the central ray or X-ray beam enters and where it exits. So when we're doing a chest X-ray, for example, you've seen the patient stand up against the bucky, which is the board where the image receptor is, and they put their chest up against that. And then the X-ray beam typically enters their back, so they're posterior, and comes out the anterior. So that would be a PA chest X-ray. Whereas if we go to a patient's room and we do a portable chest X-ray and they're sitting up in the bed, we would usually put the image receptor behind the patient, and then the central ray or X-ray beam would be entering the patient from the front, which is anterior, and be exiting posterior, and that would be an AP chest X-ray. So those are the things that we talk about with projection. Also on your images, you want to look for the markers. Your technologists should use markers to mark the right and the left on the patient. Additionally, those markers usually have the technologist's initials as well, so you can see who performed the exam. Also, we are concerned with radiation protection, so we want to make sure that we collimate the beam whenever possible. Detail, we want to make sure that it is nice and crisp. There are no artifacts such as clothes or different types of accessories the patient may have on that are detracting from the anatomy. We also want to make sure that the brightness and the contrast of the image are appropriate so that it is diagnostic. Every image that is created needs to be critiqued. And when we look at that, what we want to do is look to see if it meets the acceptance limits for that type of procedure. Additionally, if there is a problem, what is the cause of that problem? Was it technical factors? Did we use incorrect technical factors to perform the exam? Was it a procedural issue, like positioning, or maybe the patient moved during the exam? Or was it an equipment malfunction? After we've determined what the cause of the problem is, then we can determine what we can do to correct the problem. The most commonly ordered procedure is going to be a chest X-ray. So how do we know if a chest X-ray is good? Well, there's a lot of things that we look for. Our evaluation criteria involves several things. First, we want to see 10 ribs above the diaphragm. Second, we want to see no rotation for the patient. Third, no motion, so the patient should not be breathing during the exam or moving at all. We want no artifacts included, and we want to make sure that all of the anatomy is included on the image. So as we go through the images that we're going to look at shortly, we're going to look for these different things to determine whether or not the chest X-ray is diagnostic. Let's start with this PA chest X-ray. Here's a typical PA chest X-ray. So first, what did we say? 10 ribs above the diaphragm. So let's count the ribs. Here's the first rib, and you can see how it kind of curls around right here. That's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So we have 11 ribs above the diaphragm. That shows us that this patient has a good inspiration. So we're seeing a good bit of the lung volume. The next thing that we want to look at is, are they properly positioned? So we want to look for rotation. On our chest X-ray for rotation on the PA, we look right here at the sternoclavicular joints. They should be about equal distance, and on this patient they are. The next thing we also want to look at on positioning is whether or not the patient has removed their scapula from the lung fields. When we have our patient against the chest bucky, we ask them to rotate their shoulders forward. When they do this, this helps to remove the scapula from the lung fields. On this patient, you can see the scapula right here. This border is still within the lung field, and you can see that the same on the other side right here. So we could have done a better job with having them rotate their shoulders forward. But they have a good inspiration. We have good technique. We can see lung markings throughout the chest. It's not very rotated. We have our marker up here showing us the left side of the patient's body. And overall, this is a pretty good image. Let's look at another PA chest X-ray. So here, let's count our ribs again. Let's start with rib 1. See how it curls around. 2, 3, 4, 5, 6, 7, 8, 9, 10. We have 10 ribs above the diaphragm, showing us that the patient has a good inspiration. Also, notice that the scapula now are rotated out of the lung fields. So that is some better positioning that we have. We are going to look at our sternoclavicular joints again, and we see just a slight bit of rotation on this patient, but it's not very much. We have our marker at the top here showing us the left side, and so overall we have a very good image. Let's look at a chest X-ray that's maybe not as good. So if we look at this image, we can see we've got some problems here. Well, first of all, if we look at how it's positioned, we notice that we have the apices of the lungs included, but the costophrenic angles have been clipped. So we do not have all the anatomy included here. Clearly, this image needs to be repeated. Also, it looks like the technique isn't very good. It's kind of hazy overall and maybe could be a little bit darker so that we could see things better on this patient. So this would definitely be an image that needs to be repeated. Here's another image that has some issues. Now, this time, we've included both costophrenic angles. We can see those on the patient, but now we've clipped the apices. So again, we have anatomy that is missing from this chest x-ray, and this image would need to be repeated. Here's another chest x-ray that has some problems. So let's look at this one a little more carefully. When we look at it, we can tell all the anatomy is there. We have the apices, we have all the way down to the costophrenic angles, but there's something else going on. Let's look at the number of ribs that we have. 1, 2, 3, 4, 5, 6, 7, maybe 8. So not a very good inspiration on this patient, and we can tell that. We can see that there's a good bit of lung that we can't see here. We need this patient definitely to take a deeper breath. It looks like their shoulders are rotated forward properly. There is a little bit of rotation here at the sternoclavicular joint, but definitely this would be a situation where we would want to try to get this patient to take a deeper inspiration. Now, all of you know that from your clinical findings and when you are talking to a patient, some patients may not be able to get any fuller of a respiration. So this is something to keep in mind as well. We have to do our best to try to get the deepest inspiration we can when we take our image, but there's sometimes that patient condition is going to not allow that to occur. Let's look at another image. There's several things on this image that we want to look at. There's a lot going on here. So first, let's start with, does the patient have a good inspiration? We have 1, 2, 3, 4, 5, 6, 7, 8, 9, part of 10. So a pretty good inspiration for this patient. One of the things that you're going to notice is this marking down here on the bottom. So this is AP sitting 56 inches distance. Why does any of that matter? Well, for one, our chest x-rays are typically done PA, and that's for a reason. When we are taking an image of anything, the closer the part is to the image receptor, the less magnification. So our heart sits in our body more toward the anterior aspect of our chest. So when we put our chest up against the bucky for a PA chest x-ray, we're putting the heart closest to the image receptor, thus reducing magnification. So when we take an AP chest x-ray, so that means it's further away from the image receptor, and therefore it's going to cause more magnification. So that's one thing to keep in mind. Sitting. What does sitting matter? Well, we want our patients to be sitting upright whenever possible so that we can see air fluid levels within our chest x-ray. If a patient is laying down, those can be obscured. So sitting tells us the patient is upright and erect. Next thing that you see here is 56 inches distance. Chest x-rays are done at 6 feet, 72 inches. So when we have to do it at 56 inches, typically this is because we're doing it portable, and we can't get 72 inches due to the confines of the area that we're working in. So all of these things tell you something. The 56 inches you think may not matter, but it does, because the further it is away, the less magnification. So because they're doing it at a closer distance, we're going to have more magnification, as is the AP going to make more magnification. So these are just things to know whenever you're looking at an image. Additionally, since it was done AP, you can see that the scapula are clearly in the lung fields. It's much harder to do that whenever a patient is upright to get them to get their shoulders rolled forward. Also, we notice that this patient has a chest tube here, and so that is another clue that something else is going on with this patient. So this patient has a pneumothorax, and this may be difficult for you to see, but you see all these little white hazy things within the lung. Those are the lung markings that I was talking about. When a patient has a pneumothorax, you'll see a clear area where there is no lung markings. So if you notice over here in this lung, this patient has lung markings, but if you look up here at the very top, you see how clear it is and there are no lung markings up there? That's because that's where the pneumothorax is. So let's look at a different position now. Let's look at the lateral chest X-ray. When we do a lateral chest X-ray, we're going to have the patient stand with their left side against the image receptor or bucky, and we're going to have them raise their arms above their head, and so now they're in a lateral position. Again, we want the left side against the image receptor because the heart is more on the left side of the body, therefore it's closer to the image receptor that way, reducing magnification. So what are we going to look for on our chest X-ray on the lateral position? Well, we want some of the same things that we want before. We're going to want to make sure that all of the anatomy there, that the patient is positioned correctly and has a good inspiration. So when we look at this image, we can see that our patient has a nice good inspiration. They're in a lateral position and we can see the blocking of the thoracic vertebra. And we can also look, where we really look for rotation is in the ribs. And so we want to look at these posterior ribs. We want them to be essentially superimposed on each other. You can see that right here, you can see one set here and the other one there. One here, one here. So this patient is 1 and 1, just like that. There's 1, there's 1. And you can see the slight little tiny bit of distance between those is a little bit of rotation on this chest X-ray, but not a lot. Another thing that we want to look for is that the arms are up out of the lung fields. We don't see the humerus. They're above the head, and so they're out of the way. You can see these right here, this line and this line, that is the scapula. We're looking at them on end, and so they're going to just appear as a line. Here is our heart. Again, we see the costophrenic angles back here, and our patient is in good position. We see the sternum nice and straight up here in the front. Again, we have our left marker, and so this is a good lateral chest X-ray. Let's look at another lateral chest X-ray. You can tell there's quite a bit of difference between the two that we looked at. The previous one had a nice good inspiration. We could see a lot of the lung, and on this one you can see that first of all we don't probably have nearly as good of an inspiration. Here's one costophrenic angle, and we may have even clipped one, so there's a question there. Right here, this is again the scapula. Here's our sternum. They look to be pretty straight, but our technique isn't very good. Look how washed out it is here. And so we really need to do a better job of penetrating these lungs on this image. Here's another lateral. Now when we look at this one, we can tell that all the anatomy is on there. We have the top, the apices, and we have one costophrenic angle and a second costophrenic angle, but they should be superimposed essentially. We can see one set of ribs kind of going up this way, and then we see the other set here. So there's a big separation right here between those two sets of ribs. We've got a lot of rotation, so our patient isn't very lateral. We would need to reposition this and repeat this image. Another lateral chest X-ray. Here we have the patient appears to be in pretty good position. We can see the two sets of ribs. Here's one set and then there's the other. There's only a slight bit of difference, so there's a little bit of rotation there. But again, now we don't have both the costophrenic angles. It appears that one of them is down here in this blocker area. So again, we've cut off some of the anatomy from this image, and this would need to be repeated as well. The PA and the lateral chest X-ray are the most common views that you're going to do for the chest, but there's a lot of others that we can do as well. When we can't do a PA chest X-ray, when we do a portable chest X-ray, we're going to do it AP. And for the lateral, again, that's going to be something that we're going to do in the department. We're going to do a lateral chest X-ray. But there's a few other positions that I just thought I'd make you aware of as well. This image is a Decubitus chest X-ray, and you're probably wondering why it's on its side. Well, that's how the patient is laying. For this, the patient would be laying on a stretcher or a bed, and they'd be laying on their side in a lateral position. You're going to want the left side to be down, and you want the patient's arms raised over their head. So it kind of looks like an AP or a PA when you're looking at it, but the patient is laying on their side. So for this image, we can see that we have the apices of the lungs. It looks like we've cut a costophrenic angle here, and in addition to that, the marker is in the middle of the anatomy. So just for those two reasons alone, this image would need to be repeated. But when we do a Decubitus chest X-ray, what we're typically looking for are fluid levels. And so on this one, what you can see is down here at the very bottom, this little white edge here, this is a fluid level, and you can see how it's leveling off in the lung down here, so we're able to see the fluid in the lung. This image looks like a chest X-ray, like a PA or an AP. However, it is slightly different. This is actually something called a Lordotic chest X-ray. If you remember when we were looking at the AP or the PA chest X-ray, the clavicles were down in the upper part of the apices of the lungs. They were right up here. When you want to see something that is in the apices of the lung and you want to move the clavicles out of the way in order to see that area, then you can do something a Lordotic chest X-ray. This exam can be done two ways. One, we can take the X-ray tube and angle it to project the clavicles above the apices of the lungs, or two, we can have the patient step forward from the image receptor and then lean back against it so their body is at somewhat of an angle, which again projects the clavicles above the apices of the lungs. This image probably looks very distorted to you, and in a way it is. This image is an oblique chest X-ray. On occasion, you can do an oblique chest X-ray to look at something in a different position and to look at it as you move the patient's body. Oblique chest X-rays are done with the patient at a 45-degree angle. So you can see everything is pretty distorted, but that's because of how the patient is standing. You can see here the clavicles coming across, and this is the sternum right here. You actually can see it very well. So here's the upper part of the sternum right here. Here comes the body of it down here and all the way up around to here. So actually that's a very good image of a sternum. Imaging the sternum is probably one of the hardest things, and plain film is not necessarily the best way to image it, but here you can see the outline of the entire sternum laid out. So this is an oblique. We've talked a little bit about making sure that when we take our images that the patient is positioned properly and that there are not other things within the part that we're trying to image. We don't want artifacts on the image. We only want the patient themselves so that we get anatomy and not things that shouldn't be in the image. These are going to be some images that show you some of the different types of artifacts. That some of them may be things that you can remove, and some of them are things that you just have to live with. So hopefully this will kind of give you an idea of what we're talking about. For this first image, we have a couple of things that are going on here when you look at this image. At first glance, you look at it and you are looking at the anatomy. We have our costophrenic angles, we have our apices of the lungs, we have our clavicles, maybe a slight bit of rotation. We also have a little bit of the scapula in the lung field, but there's some other things going on here. So if you look at it very carefully, there's two very specific artifacts that are present on this image. First, if you look over here, you can see the patient's glasses case and their glasses within it. There's their glasses. The second thing that you see is that part of the image is a little bit darker than the rest and part of it is lighter. If you notice a very distinct line here and down to here. So what's happened with that is it looks like that this image receptor was left in the room with another image receptor in front of it when another exposure was made. So clearly this image is not of diagnostic quality because we have definitely two different shades going on here because of the image receptor being placed on top of it, and also we have the patient's glasses in the middle of the anatomy. Here's another image that is not of diagnostic quality. When we look at this image, we can tell that there are some problems here for sure. Definitely not well penetrated, definitely needs an increased technique because we can't see the lung fields very well. But more importantly, this is likely a portable chest X-ray and one done where the patient's head is hanging down into the middle of their apices of their lungs. So clearly that is not acceptable. We would definitely need to get this patient's head removed and leaning back so that we can see all of the lung fields. In addition to that, we would need to make this a darker image so that it really penetrated the lungs and made it diagnostic. Here's another image that clearly has an artifact in it. Overall, it looks like a pretty decent image at first, but if we look really carefully down here in the bottom of the left lung, we have a pill container. So we have a patient that had their pills in their pocket when the image was taken. So again, this image would need to be repeated. When we take a chest X-ray, we typically tell the patient to take everything from the waist up off. There's a reason for this. As you've seen in some of the other images, people keep things in the pockets of their shirt and those will show up on the image. Sometimes if they have buttons, it'll show up on the image. If there's a t-shirt with a heavy screen print on it, those can show up. Bras, a whole variety of other things. So it's best just to have the patient put on a gown. Here's an image where we have the patient who has not been properly dressed, and what we can see here is the head of the zipper. And so again, had the patient been properly dressed, we would not need to repeat this image, but we do because now we have a zipper in the middle of the anatomy. For this image, we have a different type of artifact. This is an artifact that we really probably can't do much about. This patient has swallowed a spoon. How they swallowed a spoon, I do not know, but people do strange things. And so in this instance, the patient has swallowed the spoon, and so that is present on the image. We can't get rid of the spoon. That is up to someone else to do, but there's definitely an artifact in this image. Here we have a pediatric patient who has swallowed a quarter. You can see the quarter right here in their chest. When we're looking for an object such as this that the patient has swallowed or has inside them, we need to take two opposing positions. We need to take two images at 90 degrees from each other. So while we can see the quarter is clearly here, to really get an idea of where that quarter is, we would also need the PA view to go along with this. As I've mentioned, radiologic technologists do not make a diagnosis. We are in charge of creating an image that is of diagnostic quality to be read by the physician or the radiologist to give a report to the patient. But in these next images, I'm going to show you some pathology that you might see on the images and allow you to make the diagnosis from it. Things that you might be looking for when you're trying to find something on an image. Just a few of those kind of little things. You'll learn more about how to actually diagnose and read images at another time. From the PA chest X-rays that we've been looking at previously, we've looked at the costophrenic angles. You've noticed that those had been very sharp and pointed. If you'll notice on these that they're a bit blunted here and here. This one not so much, but this one definitely. When you see blunted costophrenic angles, typically that is indicative of fluid in the patient's lungs. Similar to the previous image, you can see that on this lateral chest X-ray, again, that the costophrenic angles used to come down and be pointed down here when we had seen previous images. You'll notice on this one how it comes straight across like this, again, indicative of fluid in the patient's lungs. When we look at this image, clearly there's something going on. When we look at this image right here, we can see this costophrenic angle is nice and sharp, as it should be. This right here, if you'll notice, this is the diaphragm, and this is air in the stomach. That is what this big air bubble is. So on any kind of chest x-ray, dark areas are filled with air, so that is lungs, so they are filled with air. When they are white like this, then that indicates that there's something else going on. So in this patient, this lung, and you look right here, is nice and leveled off. So again, this is all fluid in this area. And so this patient has a nice little air fluid level, and this is all the air that they have in that lung. We have quite a bit going on in this image. As we can see down here, first of all, this is a film screen image, and there is a sticker down here telling us that it was done portable. So we know that this was likely done in the emergency department. If you notice this white area right up here, that is a C-collar that is still on this patient. So this is a trauma patient. This patient, you can see all the leads to the monitors that this patient is hooked up to. And in addition to that, we can tell that there's quite a bit of trauma that's going on here in this chest x-ray. If you look, there's multiple fractures that this patient has. Here's a broken clavicle here. Here's another broken clavicle here. We, in addition to that, have multiple rib fractures. There's a rib fracture here, here, here. All throughout their lungs, all throughout their chest, they have multiple fractures. So this patient is definitely has some issues going on in their chest x-ray. Here's another patient that we are looking at, and if you remember from the previous one, when we had the air fluid level, it looked kind of similar to that over here. But what we have here is a little bit different. Again, we can see that the stomach is got air in it here, and in addition to that, this lung looks nice and clear, but over here we don't see anything over here. Notice there's no lung markings at all, and we also see these staples from a surgery. So this patient has actually had their lung removed. And so when the lung is removed, we'll no longer see the lung markings over here or see the air that would be normally there, so it's going to appear white on the image. Here we have another PA chest x-ray. When we look at it, it appears all the anatomy is present. We have all the way to the apices to the costophrenic angles. It looks like we have very little rotation here, a good inspiration, pretty good position chest x-ray. But let's look a little bit closer at this. When we look at the left lung over here, we notice that there's lung markings all the way out in this image. But when we look over here at the right lung, we notice again lung markings until we get right down here at this costophrenic angle, where you'll notice that it's very clear. That is a pneumothorax. You can actually see the edge of the lung right here, and down here there is no lung, so we have a pneumothorax for this patient. When looking at our chest x-rays, we always want to pay attention to the left and the right. Again, here we have our left marker, so we know this is the left side of the patient's body. And on the left side, we've noticed before that there's a lot of times bowel air, or there's air in the stomach that is over here by the diaphragm, very common. But then on the right side, when you look at the patient, that's where the liver lies underneath that diaphragm. So there should be no air under the diaphragm there. If you'll notice right here where this arrow is pointing, this is the diaphragm coming across here, and underneath the diaphragm there is air. So this patient actually has free air in their abdomen. This image demonstrates a complete lack of radiation protection. This is a pediatric patient. As you can see, the patient is being held likely by their mother or father, and the mother or father's hands are being exposed during the exam as well. In addition to that, instead of just being a chest X-ray or an abdomen X-ray, we have the chest, we have the abdomen, we have the whole pelvis, we have humerus, we have a mandible here. We have entirely too much of this child being irradiated. When we do pediatric images, they need to be at the very least collimated down to the part that we want to image and show nothing more. If someone is holding them, they should certainly not be imaged during part of the imaging of the patient as well. So this is a demonstration of very poor radiation protection and very poor imaging practice. Here's another image that demonstrates poor imaging of a pediatric patient. Again, it is not well centered or positioned. We have the entire skull of the patient for this lateral chest X-ray, and the patient isn't even centered on the image receptor very well. Additionally, it's clearly too light and we are unable to see the lungs at all. So this image would definitely need to be repeated. Now that we've finished looking at chest X-rays, another common exam that's often ordered is the KUB or abdomen. KUB standing for kidneys, ureter, and bladder. So when we do a KUB, we're going to be looking for an image that has a lot of contrast. We also want to make sure that all the anatomy is included. We want to watch for motion. So we want to do, again, have the patient hold their breath, no rotation, and no artifacts. When we're looking at these images, it's going to be a little bit different. Abdomens are going to be more difficult to penetrate with X-rays because we're looking at dense tissue, whereas the lungs were filled with air, which is easy to penetrate with X-rays. The abdomen is lots of soft tissue, bones, muscle, lots of other things, and it's going to require more radiation to penetrate an abdomen image. When we look at an abdomen image, the first thing we want to do is to make sure that all the anatomy is present. So we want to make sure that the kidney, ureters, and bladders are present. However, those parts are not easily discernible without contrast. So we have to depend upon our anatomic markings. On this image, since we are seeing right here, we are seeing the diaphragm, we are sure that the kidneys are included. And on the bottom part of the image, if you look, we have a symphysis pubis down here, and therefore the bladder is not going to be below that, so we have the bladder. And the ureters are somewhere in between, so therefore we have all of the anatomy included on this image. When we look at it for rotation, the next thing that we want to do is we look at the pelvis and the spine. If you notice, the wings of the pelvis here are about the same size, so our patient is not rotated. Another thing we can look at are right here on our spine, all completely lined up, so we can see that they're not rotated here as well. One of the things when we're doing an abdomen X-ray that makes it difficult is a lot of times you can see the outlines of the kidneys, but if the patient hasn't been well prepped or prepped at all, then we may not see them. As you can see on this patient, we see a lot of air in the abdomen. So that's obstructing where our view of the kidneys. So we know they're in this area somewhere, but we can't really see the outlines of them well because the patient has so much gas and fecal material present. Here's another abdomen image, and as we can see on this one, again, we have all the way down to the symphysis pubis, and so we know that we have the bladder on there. Again, the kidneys are likely obstructed by the large amount of fecal material and air that's in the abdomen, so it's very difficult to tell. But something else that we can see on this image that was not as clear on the other image is the psoas muscles. If you'll look right here, and here, these are the psoas muscles. This shows that we have very good penetration of the abdomen and that our technique is appropriate. When we do an abdomen x-ray, we want to see all these soft tissues. We're looking for those. It's different than the lumbar spine. When we're doing a lumbar spine, we're looking at the bony detail. On an abdomen, we're looking more at the soft tissue. So when we can see good psoas muscles, we have a good technique that's been used on the image. Here's another image of the abdomen, and again we can see those psoas muscles here coming down. Our patient isn't rotated, they're nice and straight. We can see the bottom border of a kidney here. And I believe that may be one over here, but again we have lots of gas and fecal material, so it's very difficult to tell. But we likely have the kidneys included on this image as well. But what we don't have is the bladder. If you'll notice at the bottom, the symphysis pubis has been clipped. All we have to see is the very upper edge of it in order to know that it is present on there. But when we've clipped any part of it, then we've clipped that part of the anatomy. In this instance, what the technologist would need to do is go back and get another image, either of the entire abdomen, or they can just get a bladder x-ray where we show that we have all of the anatomy present that's required for the image. In addition to the KUB, which is done with the patient supine, there's also the erect abdomen that can be ordered. Erect abdomens are typically done to look for free air in the abdomen. Since we're looking for free air, as we looked earlier on the chest x-ray and identified free air, we know that free air is going to be on the right side of the abdomen, right below the diaphragm, above the liver. So that would be over in this area. So when we do an erect abdomen, we want to be able to see both diaphragm present on the image. Again, remember that on the left side we have the stomach and bowel that push up, and so we will see air here. So this is where we're going to look for free air, is on the right side of the abdomen, below the liver. So on an erect abdomen, we're not looking for the kidneys, ureters, and bladders. We are looking for free air below the diaphragm, so we want to be sure that both diaphragm are included. You'll notice that this marker right here tells us this patient is erect, and so we know that this is an erect abdomen. I included this image for you to see something a little bit unique. When you look at this image here, you can see that it's not very well penetrated. That definitely, it's very difficult to see what's going on in this abdomen at all. But if you look more closely, you may notice something else that's going on here. If you look right here, that is the skull of a fetus. Here's the spine coming down. It's very faint, but you can see it. And then we can see the extremities here on the baby. So this is an abdomen x-ray that is taken of a pregnant patient. You ask why this may be done. There were times in the past where these were done, a lot of times to see the position of the fetus. You can see that this child is probably near term, and in which case the child is less sensitive to radiation at that point. It's in the first trimester that we really try to avoid imaging any pregnant patients at all. But this patient is clearly past that. However, it is not common practice at all to image a pregnant patient. If this were ordered and I was the technologist that received this order, I would do a lot of double checking with their physician as well as the radiologist before obtaining this image. For this next portion of the presentation, we're just going to talk about some different types of other exams that may be ordered and some things that you're going to want to look for on those. On extremities, one of the things that you really want to look for is bony detail. On any long bones, you want to make sure that both joints are included. For example, on a forearm, you'd want to make sure that you had all the way from the wrist to the elbow. You also want to make sure that you have good positioning. On those images, you want to make sure that they're well positioned and all the anatomy is included. no motion. Again, we don't want our patient to be moving during the examination. And most importantly, we want to make sure that we have two opposing views at 90 degrees from each other. This image here above shows you a knee x-ray of an AP and a lateral of a knee, two views that are opposing 90 degrees from each other. All extremities should include at least two views. For the cervical spine, typically we are looking at all 7 vertebrae, and if we're going to do a full series, then what we're going to want is an AP, a lateral, an odontoid view, and also both obliques. You want to make sure that when you do the odontoid, that the entire odontoid is included on the image. The intervertebral foramina should be open on the obliques, and you should see all 7 vertebrae. Sometimes this is very difficult, especially on the lateral, because the patient may have shoulders that are in the way of the lower cervical vertebra. So when you get to about C6 or 7, sometimes it can be difficult to see. There's an additional image that can be done, but these days, most of the time, these patients are sent to CT to be able to clearly see the lower cervical vertebra, especially in trauma situations. For the thoracic spine, we want to see all 12 vertebrae. And again, we want to make sure that we include all of them from the very top to the bottom. And if you think about the thoracic vertebra, some are in the chest and some are in the abdomen. So getting the right technique that shows them both when some are have a lot of contrast due to the lungs and some have lower contrast due to the abdomen is a little bit tricky sometimes. We want to make sure that we see them all, and sometimes this takes multiple views. A thoracic spine typically just includes an AP and a lateral. Sometimes we do an additional view, which can be done for the thoracic spine or for the lower cervical vertebra, and it's called a swimmer's view. This shows the lower cervical and upper thoracic vertebra. Also, on the thoracic spine, on occasion, when you look at the lateral, you will see motion. One of the reasons we do this is so that the patient will breathe throughout the exam of the lateral, and what this does is it blurs the ribs and makes the spine more clear and easily to see, because that way the vertebrae are blurred because they're moving during the breathing of the exposure. Next, we have the lumbar spine, and the lumbar spine is in the abdomen, and so for this, we want to see all 5 lumbar vertebrae. We want no rotation on the AP or the lateral, and we want to make sure that we have good technique. Remember that when we were looking at the abdomen, we were looking more at the soft tissue, so we wanted to be able to see all those shades of gray. Now that we're looking at the vertebra, we're going to want this to have much more distinct contrast. So we really want to see the bony detail more so than the anatomy that's in the abdomen. So the technique is a little bit different than what you would see on an abdomen x-ray. I also wanted to include this great image resource. This website has a lot of different images that you can use, especially when you're looking at something and you're not 100% sure what you're looking at. It gives you a lot of examples of pathology that you may want to look at, just to give you some ideas of what to look for whenever you're looking at specific pathology or specific images. I think it's a great resource that you may be able to use. And finally, I want to thank you for your attention. I hope that this helps you a little bit to have a better understanding of what should be on an image and what you're looking at when you see it. Please feel free to always go and talk to the technologists that took the images and ask them to repeat it in any circumstances that you're not comfortable, or ask them questions about the patient and what happened when they took the image. It's always better to have good communication with your technologist and get exactly what you need to make the diagnosis that you need to make. If you have any questions or anything I can help with, please feel free to contact me. I'm Dr. Laura Aaron. My email address is carwilL@nsul.edu. Hope you all have a great day, and thanks again.